Hello everyone, welcome to Ortho Implants for Life. We again have Dr. Anupam Das with us to answer your queries. Welcome Dr. Das to our channel. We are really grateful to you for joining us and taking us your precious time. Thank you so much.
Thank you.
Really do appreciate your presence.
Thank you, my pleasure.
So let's get started. Today we will discuss the questions sent by some of our viewers. So first question comes from, the name I cannot pronounce because it is some other language I do not know. It's right here in the screen. The question is, after surgery, should the plate be removed in case of distal radius fracture, Philo's plate? And will there be any complications if it is left inside?
See, I think this is the third session we are discussing, and almost one question has come in common, that is whether the plate or the implant has to be removed or not. As I told in the previous sessions also, that if it is made up of a ferromagnetic substance such as stainless steel, then after a certain period of time, once the bone gets united, it has to be removed. It's better to remove, because in that case, in case of an urgent need for MRI, it cannot be done. So it is better to remove once the bone gets united. But if it is not ferromagnetic, suppose it is MR compatible, made up of titanium, then it is not required to actually remove the plate or the implant unless it has got some indications, which mainly includes the mechanical impingement of the plate screw or the nail, or some infection which has happened to it, or some irritation which is caused by the implant action. So in those cases, we need to actually remove the plate or the screw. And as it is discussed in distal radius fracture, sometimes the screws may impinge on the extensor tendons. Then we need to remove it. And also in case of Philos, there might be some screws which may protrude into the joint, but ideally it should not. In that case also it has to be removed.
Thank you, Dr. Das. So what I have understood is that there is no straightforward answer. So the patient may have an idea, but it would be always advisable that the patient should consult the surgeon, because
it's always
taking the call himself would not be advisable.
Exactly.
Am I correct, Doctor?
Yeah, sure.
Thank you. The next question is from Achilles Dubey, who says, "Sir, my age is 38. I have a tibia plateau fracture 2 years ago. I removed buttress plate. Should I remove buttress plate or not?"
It is almost the same thing. If it is usually the implant which was used was titanium, there is absolutely no need unless it is causing any restriction of the knee range of motion or any impingement, especially by the screws on the medial side of the knee.
Thank you. Next question comes from Gavin Singh. He asked this question in the Philos plate video. He has a plate fixed on his shoulder and he is unable to raise his hand. It's been 3 months, and he asked that, can he again lift his arm?
See, Philos plating for the proximal humerus fracture may result in less or restricted shoulder range of motion, as because following the plate fixation, patients are very much reluctant to do the shoulder range of motion, but ideally it should not. Once the surgeon is confident enough about its fixation of the fracture, he should encourage the patient to move the shoulder at least passively or with the assistance of another hand at the ipsilateral elbow, so that the shoulder range of motion becomes normal as soon as the pain goes on. Otherwise, what happens if the patient is made to not move the shoulder for a while, then there is a shoulder range of motion stiffness, and which will cause trouble in long term. Now, as it has been observed that since the patient has almost passed 3 months since surgery, it is very difficult now to regain the full range of motion, but it is always advisable to actually go to a consultant orthopedic surgeon and also to get him or herself examined, so that they can actually find out the result behind the stiffness and can do accordingly by means of a physiotherapy or something. Sometimes the range of motion may get restricted because of the screws, which are very unlikely in inevitable circumstances where it may protrude into the joint that cause pain while shoulder range of motion.
Great, Dr. Dash. So I hope, Govind, if you are watching this video, you have got the reply, and you should take immediate action as Dr. Das has suggested. So next question comes from Aris Doria. He asks, can interlocking nails be used in non-union tibial fractures with callus formations already?
Okay, yes. In callus formation, where there is a non-union because of lack of stability, especially in the long bones as in the tibial fracture, addition of implant will add to the stability and may accelerate the union.
Thank you, Dr. Dash. Next question is from Damodaran. He wants to explain him about lateral patellar fassectomy.
Fassectomy. Yeah. Am I audible?
Yeah, absolutely.
So actually, lateral patellar fassectomy is a procedure. Usually nowadays it is done arthroscopically, where there is chiefly the patellofemoral joint arthritis. Okay, so that means the arthritis between. Normally there is a arthritis between the tibia and the femur, so it is the tibiofemoral, and sometimes there is isolated patellofemoral. Means there is arthritis between the rubbing surface or the articulating surfaces of the patella and the trochlea actually of the distal femur. So in that case, arthroscopically we can remove a part of the lateral facet of the patella and also the osteophytes along the border. And this is done usually arthroscopically, which may relieve the symptoms, mostly the pain for the patients, and which will help them to regain actually the normal function following this process.
Thank you, Doctor.
If you have enjoyed the video, like it, share it. If you are new to our channel, subscribe it. Hit the bell icon to get the notifications for our upcoming videos. If you have any queries, comment below and we will surely reply back. Thank you and see you in our next video.